Alzheimer's disease, once more. You must know everything, anything about it. Once more, AIMS November 2011 question. The number of plaques, does it correlate with the severity of the disease? Yes. And the neurofibrillary tangles, they are made up of tau protein. And number of tangles definitely correlate with the dementia. And where are these neurofibrillary tangles? Are they intra or extracellular? That is what we are going to debate now. The neurofibrillary tangles are fundamentally intracellular. Now what are the various features of Alzheimer's disease, doctor? Neuritic plaques, neurofibrillary tangles, amyloid angiopathy, and granulovascular degeneration in Hirano bodies. So you need to remember it like a geography lesson, all these important newer terminology. Now, what is a neurofibrillary tangle basically? It is flame shaped or globose, which is seen in the cytoplasm of the neurons, and we use Bilskovsky's silver staining. If you have done MBBS from Russia, at least one question it will help you is in this. Bilskovsky's silver staining is one which is used for the neurofibrillary tangle. But what are they made up of? It is this hyperphosphorylated tau protein which constitutes the major composition of the neurofibrillary tangle, and once the neuron dies, because the toxicity created by the tau protein, this neurofibrillary tangle will be dangling like a tombstone of a dead sultan in the brain, is what we have to basically remember. Now if there are a lot of plaques or a lot of tangles, that means there is a higher amount of cognitive dysfunction, and the number of these neurofibrillary tangles correlates very well with the degree of the severity, is what you need to basically understand. The patient develops paralysis of the bowel bladder, and on MRI there is a dorsal myelopathy with an intradural enhancing lesion at the dorsal level. Always dorsal matlab there is, what do you mean by dorsal? Thoracic cord is called dorsal cord. Already there is a confusion about ventral and dorsal. On the top there is a dorsal cord. I still remember telling innocently after joining MD, sir, it is not in the dorsal cord, sir, maybe it may be in ventral cord. The examiner was saying, when I said dorsal, my prof was saying dorsal cord means thoracic cord. Then I understood this is too much, that what is taught in anatomy you have to forget and start learning new terminology taught by the neurology teachers. So dorsal cord is that. Now let us look into it. See doctor, spinal cord tumors, you must be 100% sure about how do we classify. What is the most common tumor in each of the locations? Favorite question of the examiner. Fundamentally, spinal cord is surrounded by what, doctor? By meninges. Very good. So you are having what is called as a dura mater. Now there can be a tumor within the spinal cord, and there can be a tumor outside the spinal cord. If it is within the spinal cord, you call it as intramedullary. Outside it is called extramedullary. Now, a extramedullary tumor which is outside the spinal cord can be in two locations. Outside the dura or inside the dura. That means the spinal cord is surrounded by dura. Between dura and the spinal cord it can be there, or outside the dura it can be there. So you have two kinds, intramedullary, extramedullary. Within extramedullary you have intradural and extradural. Now let's talk about it. What you have here, see doctor, this is all spinal cord. So this is intramedullary tumor arising within the spinal cord itself. And what are the two tumors you will remember which will be there in this location, intramedullary location? Ependymomas and astrocytomas are the two important tumors which you need to remember. Then you have a intradural extramedullary outside the spinal cord but still within the dura. Which one? Generally it is the meningiomas. Suppose if it is arising directly from the dura only, it will try to arise, if this is the dura, outside dura, inside dura, and here is the spinal cord. So it is arising from the dura and compressing the spinal cord. So meningiomas and the nerve sheath tumors, they are the two tumors which are interdural, obviously extramedullary is what you need to remember. Then you have a extradural location, outside dura. Any metastatic lesion, breast cancer, prostate cancer, any cancer which is metastasizing will come and stop at the level of dura. Dura will be like a gatekeeper. It will say, no, no, you can't go to spinal cord, stay outside. So it will be staying outside, extradural. And but even if it is staying outside, what will it do? It will grow fat and try to push on the spinal cord. Extrinsically it can compress. One more thing what it can do, spinal cord ends at the level of the L1. After that all the fibers will be coming, which is called cordic vena. So those fibers which are coming out of the spinal cord, it can compress them. So that is what a extradural metastatic lesion can be able to do, is what you have to remember. So let us summarize, doctor. Within the spinal cord you have the interdural, intermedullary, and astrocytoma, ependymoma, hemangioma, anything. Then you have interdural, extramedullary, where meningioma, nerve sheath tumor can be there, and finally you have extradural, which is typically a metastatic lesion. What is NEET 2013, 14, 15? They are going to ask. No more giving descriptions. They will give you an illustration and ask, the middle kind of a tumor possibly could be what? Is it a metastasis? Unlikely. Because the middle illustration is demonstrating extramedullary, intradural, which is more likely to be meningioma. That is what you are going to answer in your picture book. LKG ka picture book mein. Now, once more, this gives you the typical MRI picture. Intramedullary and interdural, extramedullary meningioma, and extradural, extramedullary is a metastatic lesion. Typically how they look like. So spinal tumors, what can they do? They can destroy the tracts which are passing through the spinal cord. You know, dorsal column, spinothalamic tract, they both are long tracts. Then from the brain you have a pyramidal tract. What is that? Corticospinal tract. Or you have extrapyramidal tracts which are passing through it. Any of these tracts can be compressed if typically the tumor is located in the intramedullary location, more likely. Extramedullary, extradural tumor को compress करने के लिए spinal cord को थोड़ा time लगेगा. Finally compress तो करेगा, मगर it will take time. Now if it is arising outside the spinal cord, that is extramedullary, already we discussed, it can be extradural or intradural. Now what is this, doctor? Possibly this could be what? This is definitely not intramedullary. It is definitely not extramedullary, extradural. It is more likely extramedullary, intradural, which is more likely to be meningioma. And once you opened up the dura, you are able to see the tumor, and it can compress this phylum terminale. That's what you are able to see, a meningioma, intraoperative picture of a meningioma. Now if you say the most common extramedullary tumor, it would be neurofibroma or meningioma, and neurofibroma typically will be found in the dorsal cord, whereas meningioma is much more widespread. Because the examiner said, what did he say in the question, doctor? Bowel bladder involvement is there with the thoracic cord spinal cord compression is there, and there is an intradural enhancing lesion is there. That means it is an extramedullary intradural tumor which is causing compressive myelopathy. What is myelopathy? You have four pathies. You have a radiculopathy, neuropathy, myelopathy, then myopathy, encephalopathy. 4-5 pathies make neurology. Now doctor, so we are going to debate what is this extramedullary intradural tumor more likely to be in this patient, which is located in the thoracic cord, which is enhancing on MRI. 3 clues had been given to us. So both neurofibroma, meningioma are possible, but neurofibroma is more likely to have a predilection to the thoracic cord. Now this is a typical patient. You see, a patient who is having neurofibromatosis, he has both the kind of tumors within a single person. For you only this patient is born, because one person having the same time both intramedullary and extramedullary intradural tumor is rare. So he is having an extramedullary intradural well circumscribed mass in the thoracic cord, which could be meningioma, and there is an expansile intramedullary lesion involving the thoracic cord, which is because of the ependymoma. Already we discussed now, gliomas and ependymomas are common in intramedullary location, and both these lesions are possible in neurofibromatosis type 2. Now if you look at the meningioma, it can enhance with the contrast. Gadolinium contrast agar de diye to yahan dekhiye, you see the 2 lesions. Enhancement of it is very, very important to be demonstrated to say that it is meningioma. If it doesn't enhance with the contrast, it is more likely to be neurofibroma. Whereas neurofibroma and meningioma, both of them are extramedullary, intradural in location is what you have to basically remember. So this is before giving the contrast, and this is after giving the contrast. You will be able to see that there is a contrast enhancement. So since contrast enhancement is there, are you able to appreciate, doctor? Contrast enhancement it is there, it is more likely to be meningioma rather than neurofibroma is what you will be able to finally conclude. Now leptomeningeal carcinomatosis, if you are suspecting, how do you want to evaluate the patient, was the question of AIMS November 2011. Around 1 to 5% of patients who are having solid tumors, they will typically have metastatic lesions to their meninges, and they will have a diffuse metastasis to the meninges, and such a presentation is called leptomeningeal carcinomatosis is what you have to basically remember. Now what is the most common solid tumor which is known to lead to leptomeningeal carcinomatosis? It is the breast cancer, the most common. Even small cell carcinomas, melanomas, anything can metastasize, but breast carcinoma is the most common solid tumor leading to the development of leptomeningeal carcinomatosis is what need to be remembered. How to diagnose this? You will be doing an MRI. Are you able to see this is the meninges, doctor, top? Typically it is a thickening is there, because the diffuse infiltration by this carcinomatous metastasis diffusely to the meninges is what you are able to see typically in case of the leptomeningeal carcinomatosis. So in the modern times we are not using myelography because we are all in the era of FLAIR. What is meant by FLAIR? Fluid attenuation imaging. In MRMA we reached advanced stages of finest detection of slightest lesions in the body using the MRI. So that's the reason, but still myelography sometimes will have a role. It can show nodularities or thickening of the nerve is what you are able to see. Now there is a lower limb weakness with subdural mass. What is it most likely to be? The lower limb weakness means the thoracic cord would have been compressed, because the lower limb, the upper limb can go into the upper thoracic cord and go up, but lower limbs definitely need to pass the thoracic cord. Or it can be brain cortex. But the patient is also having a subdural mass. So that is the reason a meningioma is more likely to be a lesion which can present like a subdural, intradural, that means extramedullary lesion at the thoracic level, which will show contrast enhancement, which can present with compressive myelopathy in the form of paraplegia, can occur very much. Sometimes the meningioma can be midline. It can compress the frontal lobe, and the micturition center is located in the frontal lobe. The central control of the whether to not go for toilet or whether right time for going toilet is decided by frontal lobe. That's the reason any frontal lobe infarct or frontal lobe degenerative dementias, patients will lose the control on the bladder. Okay, doc? So, if a midline meningioma at the frontal lobe compress the cortex, then there will be both lower limb weakness and also the bladder involvement together will be the presenting feature. Now, what are the features you see in Brown-Sequard syndrome, where you have cut the spinal cord, hemisection of the spinal cord? You know very well that the corticospinal tract will be traveling down. Till which level it will travel same direction, बाद में it will take opposition party में जाके join होगा. At the level of the medulla, it will undergo decussation. But when it is passing through spinal cord, already it has decussated. You agree? So if I do transection, where will I find? Ipsilateral lower limb weakness. What type of weakness? What type of weakness? UMN type or LMN type? UMN type, because the upper fibers are interrupted. Agreed, doctor? Below the level of the transection. At the level of transection, LMN type, because Andrehorn cells there got damaged by the transection, hemisection. Okay? Then how do you identify LMN type? Flaccidity, fasciculations, they are all the features by which you will identify. And below the level of the lesion, UMN type, hence spasticity is what you typically come across. Then you are having ascending fibers, the dorsal column fibers. Now the dorsal column fibers are going up, you have transected. Finally, where are they expected to go? They are expected to undergo cross above the level of the transection, they are going to undergo crossover. So that is the reason at the level of transection they have not yet crossed, and they are carrying the touch in position. Hence touch in position will be lost ipsilaterally. But how is spinothalamic tract? It already crossed and coming up. So if you transect at this level, the spinothalamic tract is bringing the pain fibers from the opposite side. Hence contralateral pain and temperature typically will be lost. So that is what you call as the Brown-Sequard syndrome. Tomorrow a illustration like this will be given and you will be asked to identify whether it is Brown-Sequard or whether it is a syringomyelia or whether it is anterospinal artery occlusion syndrome. There are 4 to 5 syndromes involving the lesions of the spinal cord, which you have to make up. Now a 35-year-old gentleman is having excessive sleep. At 35 you will definitely feel more sleepy. But at work, attributed to sleep discomfort in the night, and he has the history of falling while partying with the friends. So what are the other features that you may find in this patient was the question of AIMS November 2011 in neurology. So narcolepsy is the disorder of an inability to sustain the wakefulness voluntarily, and it is a problem of the rapid eye movement sleep regulation, is what you have to appreciate. You know that there is NREM sleep, REM sleep. Sleep is not that easy process. Some people will go to bed and sleep. Some classmates. Some fellows will be wriggling in the bed until morning 2 o'clock. They will be talking. Tomorrow morning 6 o'clock I have to do this, do that with the patient. I need to go for duty, etc. Till morning 2:30, 3, 4, they'll still be crawling around. So some people can sleep faster, lucky guys. So what is the typical narcolepsy? Suddenly patient will go into sleep episode. You can see this baby, she lost the tone of the muscles, classically. She lost the tone of the muscles, and her dad is trying his best to raise her up. So this kind of an episodes of sudden loss of the tone and then falling into sleep of a person who is playing or who is otherwise standing is typical of the narcolepsy, is what we need to understand. So you have 4 clinical features. Tetrad of narcolepsy. Excessive daytime somnolence, morning very drowsiness will be there. Along with that, there will be features because of a sudden intrusion of REM sleep. Normally in the REM sleep, what will happen to our body? There is a atony of the muscles. Unless you enjoy REM sleep, you don't enjoy the massaging effect of sleep. You will still carry the same body pains after waking up if you did not have the REM sleep. But in these people, without any NREM, REM will walk in suddenly. So that's the reason they lose the tone and fall down into sleep. So that is a problem in them. So sudden weakness and the loss of the muscle tone without the loss of the consciousness, emotions can make them. Typical old movies may, the female actors will fall down the moment you talk about marriage. So nowadays nobody is doing that. Nowadays the boys are falling down if they are being told that they are shortly getting married. So cataplexy is a typical feature. Then hypnagogic hallucination or hypnopompic hallucinations. What does it mean? At the onset of the sleep or after waking up from the sleep, there is a development of hallucinations, and there is a muscle paralysis after awakening. That is, patient will wake up, he will be understanding what is going around him, but he is unable to lift his muscles because they are still in the relaxed state. So these are all the features. The tetrad of narcolepsy: excessive daytime somnolence along with cataplexy, with hallucinations which can be hypnagogic or hypnopompic, along with sleep paralysis, is basically called the narcolepsy. Why narcolepsy occur? What is the neurological basis of it? There is a neuropeptide called hypocretin, otherwise called orexin, which is located in the hypothalamus. It is the one which is considered to be responsible for maintaining our wakefulness, and the low levels of it is the one which is responsible for the development of the narcolepsy, is what we have to basically understand. There are many effects of orexins. The arousal state is because of them. The stereotypic behavior of us is because of the orexin. And appetite, gastric acid secretion, LH production, growth hormone production, glucocorticoid release. So doctor, we are finally slaves to the orexin. If the orexin doesn't cooperate, भूख नहीं है, रात में नींद नहीं है, and suddenly morning में sleep paralysis हो जाएगा. So all these problems will be there. That's the reason sleep is very important part of the human life, doctor. Now, Why some people have got a low orexin in hypothalamus? Is there a genetic basis? Abba ko hai, mujhe bhi hai, ho sakta kya? Haan. HLA-DQB1 has got an association. Those who show HLA-DQB1, unfortunately inheritance of this HLA genotype is, haplotype is 100%. If the father has got, if the parent is having narcolepsy, 100% genetic transmission will occur to the child also. Is what we have to basically appreciate. And we basically do some sleep studies in order to identify and discover this. And is there any treatment? Modafinil is a drug of choice, favorite MCQ of the examiner, which is the drug which is used for the management of attention deficit hyperactivity disorders and the narcolepsy. We need to answer modafinil is the drug which is responsible. Now let us talk about myelopathy, which is not a feature of myelopathy. Myelopathy means spinal cord got compressed. Why should jaw jerk should become brisk? Jaw jerk has something to do with cranial nerves. It has nothing to do with the spinal cord. Now let us look into what is trigeminal nerve, what decides jaw jerk, when will it become hyperreflexive, when will it become reflexive, everything you need to understand. Typically, if you look at the trigeminal nerve, it is a very long nucleus, doctor. It has got one spinal nucleus and which is there in the upper cervical cord, and from that spinal nucleus it receives the sensations. If you touch, if you prick, if you bite the skin on the face, all that information will be reported to the spinal nucleus of the trigeminal, which is located in the upper cervical cord. Now one of the options given was, will the pectoral jerk will become brisk in case of the myelopathy? Yes, definitely. See doctor, pectoral reflex, biceps reflex, triceps reflex, supinator reflex, these are all reflexes decided by what root value? Where are the roots arising? From the spinal cord level mein. C2, C3, C4, C5 up to C7, T1. Those root values are supplying these muscles, C5, C6, C8, T1 like that. So suppose if I am having a lesion, let us say compressive myelopathy at the level of C4, assume, or C5, very common location. C5 में कुछ डिस्क prolapse होके compress कर रहे spinal cord को. What will happen? That reflex which is dependent on the C5 will become areflexic, and below that level all the other reflexes become typically hyperreflexic. So what is the job of a neurologist? He will be walking with his broomstick of a witchcraft. Thak thak, thak thak, thak thak. He will identify. These reflexes are areflexic, below that they are hyperreflexic. Hence, bhoot kahan hai? Spinal cord mein, C5 level mein or C4 level mein hai. How will I prove that bhoot is there? Then he will be taking another witchcraft needle. He will be testing the cutaneous innervation. So C5 means there is a distribution. C4 means different skin distribution. Kis distribution of the skin mein sensation chale gaya? Then that is a proof. So, looking at motor weakness, you will get some clue which level mein problem hai, because every muscle has some root value. If that muscle is paralytic, means that particular root value level mein compression hai. That's the meaning of that. Then you will be checking sensory level. You will be checking the reflex. At the level of the compression there is a areflexia, below the level there is a hyperreflexia. You will put that calculation. A plus B is equal to 8, B plus C is equal to 9, A plus C is equal to 6. Hence A is equal to how much, B is equal to how much, C is equal to how much. Quadratic equations. So doctor, that's how you do what is called as mathematics in neurology. Now bladder. Bladder is also a muscle. Typically, it is controlled by one micturition center in the frontal lobe. It is also controlled by the hypogastric plexus of nerves, which are typically located in the spinal cord at the level of the lumbar and sacral level, lumbosacral plexus, which will be supplying parasympathetic innervation to the bladder. So any compression on the spinal cord will typically, what will it lead to? It will cut off the central power and it will make the lower motor neurons make the bladder become hyperreactive bladder. Got me? Suppose if the compression is all the way there in the sacral level only, then all parasympathetic nerves are gone. Then it become a weak areflexic bladder, LMN type of bladder. Above the level of lumbar, if there is any compression, then only central inhibition is gone, but lower level nerves then become disinhibited, uninhibited. Hence the bladder becomes spastic. So that is the reason the bladder urgency, which is a marker of a spastic bladder, also will occur when there is a compression of the spinal cord at a higher level, which is cutting off the inhibitory signals coming from the micturition center in the frontal lobe. So that's the reason bladder urgency is also a feature of myelopathy, is what you will be able to say. Now comes fifth cranial nerve. How will you examine, doctor? Now you see, you ask the patient to open the mouth. Typically he has a weakness of the pterygoids. That is the reason whenever he is opening the mouth, the jaw is getting deviated towards the side of the weakness. You see, he is closing and now he is opening. How is it? It is deviating. So towards the side of the weakness is what you will basically, examining the pterygoids is a way to examine the fifth cranial nerve. Now you will be touching, you will be basically eliciting the reflex of the jaw, and you will be seeing whether the patient is having an exaggerated jaw reflex or no jaw reflex. So suppose if there is an exaggerated jaw reflex, what does it mean? Jaw reflex is because of the muscles which are elevators and depressors of the jaw, and they are innervated by fifth cranial nerve. Fifth cranial nerve is coming from the pons. There is a nucleus for fifth motor nucleus on the pons. Fifth cranial nerve is in the pons. Suppose if there is a lesion in the pons or the lesion in the trigeminal, then the jaw jerk will behave like a areflexic lower motor neuron type of a jaw jerk. Okay, doctor? Suppose the jaw jerk is very brisk, what does it mean? The trigeminal is intact and the motor nucleus in the pons is also intact, but there are corticobulbar fibers from the brain. Corticobulbar fibers, they will be inhibiting the motor nucleus of the pons. They are interrupted somewhere between cerebral cortex and pons. Corticobulbar fibers are interrupted, and that is causing disinhibition, and jaw jerk is becoming brisk. Got my point? Now there is one more khichdi in this. After that we will get full digestion of the concept. The pons, the motor nucleus in the pons for the trigeminal receives corticobulbar fibers from both the sides. Only one side, if it is cut off, then inhibition don't stop. The other side will continue to inhibit. Only two sides, if it is cut off, then only the inhibition is gone, and you will get that upper motor neuron type of a brisk jaw jerk. Got me? So this is basically called pseudobulbar palsy. What do you mean by pseudobulbar palsy? There is nothing pseudo about it. Bilateral corticobulbar fibers getting interrupted, and the motor nucleus in the pons, trigeminal nucleus, motor nucleus in the pons, no more inhibited by the Parampita Paramatma cortico-cerebral cortex, no more can control it, hence it is disinhibited. Normally it inhibits, abhi inhibition ke liye abba mar gaye. So it is uninhibited, abhi club ko jayega, dance karega, jaw jerk will be very, very hyper reflexive. It will behave like an UMN, and uncontrollable laughter will be there, and they start crying, they'll be having a excessive laughter. It's called as pseudobulbar affect, it is called as. Okay, doctor. Generally people think pseudobulbar means something pseudo about it, nothing pseudo about it. It is bilateral corticobulbar inhibition. Now the question comes. Why should bilateral corticobulbar fibers should get interrupted? Isko kya ho gaya? Why they are interrupted? There are certain diseases like amyotrophic lateral stenosis, otherwise called motor neuron disease. That sclerotic pathology involves both the corticobulbar fibers. That kind of problem can lead to pseudobulbar situation. Then suppose if there is a very, very diffuse stroke, lot of areas switch off ho gaya, both sides it got. Otherwise generally one side will not cause pseudobulbar or UMN type of a palsy. Then what is meant by bulbar palsy then? अगर pons के nucleus में कुछ problem आ गया, क्यों आएगा? Pons, medulla, midbrain, they all get the blood supply from which artery, doctor? Basilar artery, right? You're right. Basilar artery finally becomes posterior cerebral arteries, and basilar artery is formed by the merger of the two vertebral arteries. This basilar artery stands behind the brainstem like a vascular stem and keeps supplying blood flow. If there is any occlusion to that, atherosclerosis in that, pons can get an infarct. And then if the pons get an infarct, what will happen? All muscles supplied by the trigeminal nucleus, motor nucleus, get affected. And what you have seen the earlier patient, lateral pterygoid weakness, all these features clinically will then appear, is what you have to remember. But what this patient is having is a motor neuron disease or pseudobulbar palsy, where bilateral corticobulbar fibers are gone and there is a development of a brisk jaw jerk, which is a UMN type of a hyperreflexic jaw jerk, is what you have to basically remember. Now, where is the problem in Berry aneurysm? Aneurysm is the expansion of the blood vessel involving all the three layers, you know very well. And what are the layers of the arterial wall of the blood vessel, doctor? You have an intima, internal elastic membrane, media, external elastic lamina, adventitia. Our histology teacher already died after teaching all these things, because at the level of the first year anatomy may, you feel like what is the next first show movie, did the tickets mil gaya ya nahi? All your classmates movie going management mein you will be busy, and we really don't bother to know which naru kahan gaye to kya hai, baad mein dekh lenge. Now in Berry aneurysm there is a congenital defect in the media which lead to development of the aneurysm. And one speciality of the vessels going to the brain is they have only one elastic layer. That's what we need to basically appreciate. All other vessels have an internal elastic, outside elastic, magar wahan to khali ek elastic layer hai. Now there are three types of aneurysms, vascular aneurysms basically. Some of you are going to be vascular surgeons shortly. Saccular or a Berry aneurysm is the most common type of aneurysm, and it can rupture very commonly. Then you have what is called as a fusiform aneurysm. That is, the blood vessel is expanded in all directions, generally atherosclerosis ke wajah se aorta mein hoga na, that is a fusiform aneurysm. It doesn't have a neck, and rupture is uncommon here. Then you have a mycotic aneurysm, which typically arise from the arteries, but don't confuse for mycotic. Mycotic का मतलब fungus infection की वजह से नहीं होगा. Bacteria, Streptococci are the most common cause which is responsible for the weakening of the wall of the vessel leading to the development of this mycotic or infectious aneurysm, and typically this patient is having a coarctation of the aorta along with the mycotic aneurysm of the aorta is what you need to appreciate. But what are the most common complication of any aneurysm? It is the rupture which lead to bleeding is what you are worried about.